Welcome to today's deep dive. We are pulling from a really fascinating stack of sources today.
Yeah, some incredible material.
Right, like clinical pharmacology primers,
Yeah.
foundational research papers going all the way back to the 1930s, and some modern medical case studies.
It's quite a mix.
It is. And our mission today is to explore the invisible mathematical engine that keeps drug levels in the human body within this biological Goldilocks zone.
Right. Not too high, not too low.
Exactly. We're looking at the delicate science of steady state and dosing intervals.
Which is, it's a crucial topic because of how we fundamentally misunderstand the medications we take.
Oh, completely.
We tend to view medication as like a simple switch. You get a headache, you take some ibuprofen, the headache dissipates, and you just assume the chemical did its job and vanished.
Yeah, it feels entirely transactional. Like I paid my toll and went on my way.
Exactly. But looking under the hood at the actual bloodstream, particularly with medications you take daily, it reveals a much more complex reality.
Because it's an unrelenting balancing act.
It really is. The goal is to keep the concentration of that drug in a very narrow window.
Because if you drop too low, the medication is subtherapeutic, like it does absolutely nothing.
Right, and if you push it too high, it crosses into toxicity.
So maintaining that perfect middle ground,
Yeah.
it relies on these continuous mathematical adjustments happening entirely out of sight.
Yep.
So, whether you rely on a daily antidepressant or take oral contraceptives, or honestly, even if you just habitually drink a 3 p.m. iced coffee, you are an active participant in this physiological balancing act.
You are. And to understand how we keep those drug levels in that target zone, we first have to, dismantle a very persistent illusion.
Oh, the textbook thing.
Yeah, an illusion created by early medical textbooks.
Yeah.
For decades, medical literature visually represented the concept of equilibrium or steady state as this completely flat line.
Right.
The chart showed drug concentration rising to a certain level in the blood and then just holding a smooth, uninterrupted horizontal path.
Which, to be fair, that flatline visual is incredibly intuitive.
Yeah.
When I think of a drug reaching its clinical plateau, I naturally picture a cruising altitude.
Like an airplane.
Yeah, an airplane climbs to 30,000 feet, levels off, and stays perfectly steady until it's time to descend.
Right, but the problem is that human biology doesn't offer smooth cruising altitudes. Not unless a patient is hooked up to a continuous intravenous drip in a hospital.
Oh, gotcha.
That continuous infusion is literally the only way to achieve a genuine, uninterrupted flatline, where the drug entering the vein perfectly matches the drug being cleared by the kidneys or liver.
But taking pills is entirely different.
Exactly. Swallowing a fixed dose at regular intervals, it produces a repeating waveform.
So it's more of an oscillating plateau.
Yes.
It actually makes me think of trying to keep a leaky bathtub filled to a specific depth.
That's a great way to look at it.
Like the drain is wide open, which represents the body constantly eliminating the drug.
Yeah.
And to keep the water level from draining completely, you dump a heady bucket of water in every single hour.
Right, and with every splash, the water level violently surges upward.
Yeah, and then over the next hour, it steadily drains back down.
Exactly.
So you are maintaining an average depth, but the instantaneous water level is constantly rising and falling.
That captures the dynamic perfectly. And in clinical terms, that sudden surge from the bucket, that's your peak concentration, or Cmax.
Okay, Steve.
And the lowest point it drains to right before you dump the next bucket in is your trough, or Cmax.
Seaman, got it.
The average concentration across that cycle is your equilibrium. But historically, the medical community casually blending those two concepts, the flat IV line and the jagged pill waveform, caused some serious contention.
I can imagine.
Yeah, in the 1960s and 70s, clinical pharmacologists had to forcefully correct the literature because treating that jagged waveform as a safe, flat line obscures the danger of the extremes.
Because the peak might briefly touch toxic levels.
Exactly. Or the trough might drop so low the drug just stops working, even if the overall average looks perfectly fine on paper.
Man, tracking those peaks and troughs, measuring the physical movement of chemicals through a living organism, that requires some heavy mathematics.
Oh, absolutely.
And the history of how we developed those equations is actually quite surprising. The foundation was laid in 1937 by this Swedish physiologist, Torsten Terrell.
Terrell, yes. He published a set of papers that completely reimagined how we model the human body.
Because before his work, the body was just treated loosely as a single homogeneous container.
Pretty much. But Terrell mapped the body as a series of interconnected compartments.
Right.
He recognized that a drug doesn't just sit in the blood. It moves back and forth between the blood, the fat, the muscle tissue, and the organs.
Wow.
And he used complex differential equations to describe the simultaneous rates of absorption, distribution, and elimination across all these different fluid compartments.
But the medical community essentially ignored his work for decades, didn't they?
They did, unfortunately.
And not because he was wrong, but because trying to solve multidimensional differential equations by hand for every individual patient's changing biology was a practical impossibility at the bedside.
Right. Without computers, mapping a drug's distribution through 5 different body compartments took days of manual calculation.
Nobody has time for that.
No, especially not a doctor on rounds. It wasn't until 1953 that a German pharmacologist named F.H. Dost formalized the field. He actually coined the term pharmacokinetics.
Pharmacokinetics, applying the physics of motion kinetics to drug molecules.
Exactly. And even then, it took until the 1960s for researchers like John G. Wagner to translate Tyrrell's dense compartmental math into pragmatic tools.
Tools that doctors could actually use.
Yes, Wagner gave doctors the actual parameters to manage that leaky bathtub without having to solve differential equations from scratch.
He gave them the framework for calculating exactly how large the dose should be and exactly how many hours should pass before the next one.
Which relies entirely on a biological rule called first-order kinetics.
Right. And this is where we run into a major yet completely logical misconception in the source material.
Oh, yes.
Because our intuition tells us that if we want a drug to build up to its maximum level in our system very quickly, we should just take a massive dose.
That's everyone assumes.
Like, more drug entering the system should mean it reaches its final plateau faster.
That is the most common blind spot for patients, and honestly, even for some medical students.
Wait, really?
Oh, yeah. But the speed at which a drug reaches its final equilibrium has absolutely nothing to do with the size of the dose.
Nothing at all.
Nothing. It depends entirely on the drug's half-life, driven by those first-order kinetics.
And first-order kinetics means the body clears a constant fraction of the drug over time, rather than a fixed amount.
Right.
So, okay, if a drug has a half-life of 10 hours, and I have 100 milligrams in my blood, my body eliminates 50 milligrams in that window.
Yep.
But if I only have 10 milligrams in my blood, my body only clears 5 milligrams.
Exactly. The underlying biological machinery, the enzymes in the liver, the filtration in the kidneys, it scales its cleanup effort based on the concentration it encounters.
That is so wild.
Well, the physical mechanism behind that scaling is just simple probability.
How so?
When there is a high concentration of drug molecules in the blood, liver enzymes bump into them constantly, metabolizing them at a massive rate.
Okay, that makes sense.
But as the drug concentration drops, the enzymes encounter the molecules less frequently, so the overall rate of elimination naturally slows down.
Huh.
Because of this proportional clearance, the timeline to reach clinical equilibrium is locked to a rigid schedule.
And that schedule is roughly 5 half-lives.
Yes. It takes roughly 5 half-lives for the drug input to equalize with the drug elimination.
And the progression of that math is incredibly consistent.
Very.
Like, after you take your first dose, 1 half-life passes, and you retain 50% of the eventual steady-state concentration.
Right.
At the end of the second half-life, you're at 75%. After the third, you hit 87.5%.
You're getting there.
Yeah, the fourth gets you to 93.75%. And
Yeah.
by the time you reach the fifth half-life, you are at roughly 97% of your final plateau, which clinicians consider to be functionally equilibrium.
Steady state, yeah. And the biological speedometer is completely indifferent to the size of the pill you swallowed.
Wow.
If you take a 10 milligram dose or a 100 milligram dose, it still takes exactly 5 half-lives to reach the respective plateau.
So the destination height changes, but not the speed.
Exactly. The 100 milligram dose will result in a much higher, potentially toxic final cruising altitude, but the total time it takes the body to navigate those 5 half-lives remains identical.
Looking at some real-world examples from the source material makes the implications of this math very clear.
Oh, for sure.
Take a common heart medication like digoxin. In a patient with normal kidney function, its half-life is roughly 36 to 48 hours.
Right.
Doing the math, waiting 5 half-lives means a patient has to take their pill every single day for over a week just for the drug to finally level off and provide its maximum therapeutic benefit.
Which, a week is a manageable time frame for a maintenance drug.
True.
The real clinical challenge arises with drugs like amiodarone, which is a really powerful antiarrhythmic used to treat life-threatening irregular heartbeats.
Okay.
Its half-life doesn't span hours. It spans anywhere from 40 to over 55 days.
Wait, 40 to 55 days. So an individual half-life is nearly 2 months long.
Yes.
That is insane.
It's driven by amiodarone's extreme lipophilicity, meaning it is highly fat-soluble.
Okay, what does that do?
When it enters the bloodstream, it doesn't stay there. It rapidly distributes deep into adipose tissue and organs, basically hiding out of reach of the kidneys and liver.
Oh, wow.
And because the clearance organs can only eliminate what is actively circulating in the blood, the body can only chip away at a tiny fraction of the total drug at a time.
The result being a profoundly slow elimination cycle.
Exactly.
If a doctor put a patient on a standard daily dose of amiodarone and waited 5 half-lives for it to build up to its therapeutic plateau, they would be waiting the better part of a year.
Pretty much.
And obviously, no physician can wait 8 or 9 months for a patient's heart rhythm to stabilize.
Definitely not.
So the biology forces a workaround to hack the timeline, which introduces the clinical concept of the loading dose.
Yes. When you are fighting a profoundly slow half-life, a loading dose is the only way to cheat the clock.
I sort of picture the loading dose like merging onto a fast-moving highway.
Oh, that's a good analogy.
Right. You don't gently tap the gas and wait to slowly accelerate. You press the pedal to the floor using a huge upfront burst of fuel to immediately get the car up to 65 miles per hour.
Right.
But once you hit that cruising speed, you don't keep the pedal floored. You ease off, switching to a much lighter maintenance pressure just to combat the wind resistance and hold the car steady at 65.
Clinically, that involves administering a single massive dose or a tightly packed series of large doses to physically dump enough drug into the system to bypass the 5 half-life climb.
Just skip the line.
Exactly. You instantly force the blood concentration up to the target plateau. But the critical rule here is that the loading dose only compresses time.
It doesn't change the destination.
Right. It does not dictate the final long-term equilibrium. The ultimate cruising altitude is determined exclusively by the body's natural clearance rate combined with the ongoing maintenance doses.
So if you floor the gas to reach 65 miles per hour, but your subsequent maintenance pressure is only strong enough to hold the car at 40 miles per hour, the car will eventually slow down to 40.
Exactly.
The heavy acceleration up front didn't permanently change the mechanics of the engine.
The loading dose simply buys time. But once that initial burst is in the system, we still have to manage the maintenance phase.
Which brings us to the crucial variable of the dosing interval.
Right.
Because deciding how many hours to wait between pills determines the violence of the waveform.
We are back to the leaky bathtub.
Yes. If you dump a very small cup of water into the tub every 10 minutes, the ripples are tiny. The water level is remarkably smooth.
And that happens when the interval between doses is significantly shorter than the drug's half-life.
Very little of the drug has time to clear out before the next dose arrives, so the peaks and troughs sit incredibly close together.
Exactly. But if you stretch that interval out, say, taking a pill only once every 24 hours for a drug with a short 4-hour half-life, you create a violent swing.
A huge drop.
Yeah, a massive fraction of the drug is eliminated between doses. The peak surges high and the trough crashes dangerously low, risking long stretches where the patient receives zero therapeutic benefit.
And the complexity really compounds when the patient's internal plumbing changes.
Oh, yes.
The clinical data on vancomycin, a heavy-duty antibiotic, illustrates this perfectly. In a healthy young adult, vancomycin has a half-life of roughly 4 to 6 hours.
Right.
But when that same drug is given to an elderly patient or someone experiencing renal failure, the entire mathematical model shifts.
Because vancomycin is cleared almost exclusively by the kidneys. So as renal function declines, the physiological drain essentially clogs. That 4 to 6 hour half-life suddenly stretches out to 20 or 30 hours.
Yes.
If a hospital merely follows a standard textbook protocol and administers the drug every 12 hours, they are dumping a new bucket of water into a bathtub that hasn't had time to drain.
So the trough never drops low enough.
Never. And because the trough is elevated, the next dose pushes the peak even higher.
Oh, man.
Cycle after cycle, the baseline creeps upward until the concentration crosses into nephrotoxicity.
So it damages the kidneys.
Yes, the drug actually begins to damage the kidney tubules, which in turn slows the clearance even further.
It creates a devastating biological feedback loop.
Exactly.
It's crazy because these mathematical models seem perfectly predictable until they collide with the messy reality of human physiology.
Very messy.
And when a physician or a patient's intuition about a drug fails to align with the underlying pharmacokinetics, the results can be catastrophic.
Tragically, yes.
The case studies in the source material surrounding methadone induction deaths highlight this terrifying blind spot in how we perceive medication.
Methadone is used globally for pain management and opioid use disorder. And the physiological trap lies in a massive mismatch between its clinical effect and its actual pharmacokinetic half-life.
Right.
The felt effects of methadone, the pain relief, and the suppression of withdrawal symptoms typically wear off in a matter of hours.
Because the drug redistributes away from the brain's receptors.
Exactly.
So from the patient's perspective, the drug is entirely gone.
Yeah.
And I mean, we're conditioned to trust our bodies. If an analgesic wears off and the pain returns, we assume our bloodstream is clear.
Naturally. But with methadone, the biology is actively deceiving the patient.
Their feelings are lying to them.
Yes. The physical elimination half-life of methadone from the blood can extend up to 59 hours.
59 hours.
Yeah. So the patient feels the effects wearing off and understandably requests a higher dose or takes another pill.
But mathematically, the previous doses are still sitting in their circulatory system.
Exactly. Because the half-life is so long, it requires 5 to 10 days for the blood levels to fully plateau.
So the drug is invisibly, silently accumulating in the background.
Silently stacking up. Historically, this discrepancy resulted in clusters of overdose fatalities during the first 2 weeks of treatment.
That is horrifying.
It is, because neither the patients nor some practitioners fully grasped the invisible, delayed climb of the steady state.
It is a stark reminder that half-life measures the physical presence of a chemical in the blood, not the duration of its felt effects.
A crucial distinction.
And this lack of pharmacokinetic awareness wasn't isolated to methadone either. The medical field went through an entire era characterized by digoxin toxicity before therapeutic drug monitoring became the standard of care.
Oh, right. Before we routinely drew blood to measure exact drug concentrations, elderly patients were frequently prescribed standard adult doses of digoxin.
Because physicians didn't account for the age-related decline in kidney clearance.
They didn't. The standard dose forced their individual steady-state plateaus well into the toxic range,
Causing severe nausea, visual disturbances, and life-threatening heart arrhythmias.
Yeah, it forced the medical community to realize that equilibrium isn't a property of the drug. It is a property of the individual patient's clearance capacity.
And just when you think you understand the rules of fractional clearance
Yeah.
and the 5 half-life timeline, certain medications break the system entirely.
Of course they do.
Like phenytoin, a common anti-seizure medication which operates on nonlinear or zero-order kinetics.
Right, phenytoin abandons the proportional clearance model completely because the metabolic pathway in the liver physically maxes out.
It's like a nightclub with a single bouncer at the door.
I like that.
Normally, if 100 people want to leave, the club opens 5 doors. If 500 people want to leave, they open 20 doors, clearing a constant fraction of the crowd.
Right, first order kinetics.
But with phenytoin, the liver only has that single bouncer. Whether there are 50 drug molecules or 5,000, the bouncer can only process a fixed amount per hour.
The pathway is entirely saturated. And because the elimination rate flatlines while the drug input remains constant, the half-life itself actually stretches out as the concentration rises.
Which makes dosing incredibly precarious.
Incredibly, a minute increase in a phenytoin prescription doesn't just bump the plateau up slightly.
Right.
Because the clearance machinery is already overwhelmed, that tiny extra input backs up in the bloodstream, causing a massive, disproportionate toxic spike in the steady-state concentration.
Attempting to use standard linear math on a zero-order drug is basically playing with fire.
It is incredibly dangerous.
But while the stakes are highest with these narrow therapeutic index drugs in a hospital setting, these same invisible mathematical rules govern the mundane routines of our daily lives.
Oh, absolutely.
Like millions of people rely on oral contraceptives, a system entirely dependent on maintaining a rigid hormone equilibrium across the dosing cycle.
Right. And the pharmacokinetic mechanics explain exactly why missing a single pill or even taking the pills at wildly inconsistent times fundamentally undermines their efficacy.
By stretching the dosing interval past the drug's half-life, the trough concentration drops below the threshold required to suppress ovulation.
You break the plateau.
You break the plateau. And the same logic applies to antidepressants, like SSRIs.
Oh, this is a big one.
Patients are routinely advised that it will take several weeks to feel the therapeutic benefits. And the common assumption is that the brain simply takes time to slowly rewire its neural pathways.
Which, I mean, neuroplasticity and receptor downregulation are a significant part of the mechanism.
Sure.
However, the foundational delay is purely pharmacokinetic.
It physically takes days and days of swallowing that daily pill to complete the 5 half-lives required to build the chemical concentration up to the required steady state.
The drug cannot even begin to initiate those neuroadaptive changes fully until the biological bathtub reaches the proper depth.
That is fascinating. And here's where it gets really interesting for anyone listening with an iced coffee in their hand.
Oh, the coffee effect.
Yes, this mathematical stacking effect applies directly to caffeine. Caffeine has an average half-life of roughly 5 hours in a healthy adult.
Which means if you consume a strong cup of coffee at 8 a.m., half of that caffeine is still actively circulating in your bloodstream at 1 p.m.
So when you inevitably grab that 3 p.m. espresso, you are not starting with a clean slate.
Not at all.
You are violently stacking a brand new peak on top of the lingering trough of the morning's coffee.
You are actively building a daily caffeine steady state.
Yeah, and by the time you attempt to sleep at 11 p.m., the accumulated waveform hasn't cleared.
Nope. The physical molecules are still present, actively binding to and blocking your brain's adenosine receptors, basically preventing sleep.
We're all just walking around managing our own complex pharmacokinetic profiles.
We really are, and modern clinical medicine is aggressively updating how it monitors these shifting variables.
So they are.
Yeah. For a long time, the standard procedure for managing dangerous drugs like vancomycin was to rely on a single trough measurement. Phlebotomists would draw blood mere minutes before the next dose was scheduled, checking only the lowest point of the waveform.
But checking the absolute bottom of the bathtub doesn't tell you how violently the water splashed over the top when the bucket was dumped in.
Exactly.
A single trough measurement is just a snapshot. It completely ignores the height of the peak and the total duration the patient's tissues were exposed to high concentrations of the drug.
Which is exactly why clinical guidelines have aggressively shifted toward AUC monitoring.
AUC.
Yeah, measuring the area under the curve.
Got it.
Instead of relying on a single snapshot, clinicians now utilize multiple strategic blood draws combined with sophisticated Bayesian forecasting software.
Sounds intense.
It allows them to map the entire mathematical integral of the curve. They calculate the total drug exposure across the entire dosing interval.
Because the area under the curve captures the dynamic reality of a living patient. It acknowledges that a patient isn't a static textbook equation. Their renal function drifts throughout the week, their liver enzymes upregulate, their hydration status shifts.
And the Bayesian software constantly redraws the curve to match the patient's real-time biology.
It's a massive leap forward in precision medicine.
It really is. We are no longer treating the drug, we are treating the specific metabolic capacity of the individual.
Which is just incredible. Well, our mission today was to explore the engine, keeping us in the Goldilocks zone.
I think we did that.
I think so too. We've established that steady state is an oscillating waveform, not a flat line.
Definitely.
The timeline to reach that equilibrium is dictated entirely by a drug's half-life, predictably settling around the 5 half-life mark.
Right.
And taking a bigger dose will never accelerate that timeline. Only a targeted loading dose can compress the clock.
Yeah, very true.
Ultimately, your body's individual clearance rate reigns supreme over every calculation.
And, well, acknowledging that our individual clearance rate is never truly static leads to a fascinating and maybe slightly unsettling biological implication.
Lay it on me.
Well, if maintaining this delicate plateau relies entirely on our internal rate of elimination, we have to consider what happens when our internal physiological clocks shift underneath us.
Right, because our kidney filtration rates and liver perfusion aren't perfectly constant machines.
Exactly. They are subject to circadian rhythms influenced by daily activity and sleep cycles.
Oh, wow. So the volume of blood flowing through your kidneys at 2 a.m. while you are in deep sleep is markedly different from the blood flow at 8 a.m. when your heart rate is elevated and you are active.
The physiological drain is literally expanding and contracting based on the time of day.
Which means, theoretically, a perfectly calculated maintenance dose of a highly sensitive drug, mathematically optimized for your active 8 a.m. clearance rate, could behave like an accidental overdose if your schedule shifts and you take it at 2 a.m.
It could. When your body's biological drain is temporarily narrowed, the same exact dose creates a completely different, potentially toxic waveform.
The math of pharmacokinetics might be flawless, but the vessel it operates in is constantly changing shape.
The clinical variables are constantly in motion, but understanding the underlying math is the only way we can navigate those waters safely.
That is wild to think about. Well, thank you for joining us on today's deep dive into the invisible world of steady states.
Great.
So the next time you take a daily vitamin, finish a course of antibiotics, or reach for that afternoon coffee, remember the math running in the background. You are never just flipping a switch. You are riding the waveform.